Sure. So it's a good afternoon from and on behalf of the three co-sponsors of this platform that we all, the University of Washington, Sambodhi Research and Communication Organization, as well as ISRN India, are planning to launch with the aim that will be actually discussed with the two organizational representatives who will follow soon after I finish introducing the topic. But basically, COVID-19 is what we all been spending almost most of our time gated out of the communities back into our homes, and the organizationally this epidemic or this pandemic has challenged across not only the lives but also the livelihoods. So we will possibly see what has happened in the past 4 months, and soon the speakers will take on, but I will just introduce the topic. And if I can take the slides on, uh, can I take these two slides, or you're going to help me? Um,
Sir, are you able to share screen, or would you like me to?
yeah, if you can bring me the
I'll do
slides up.
I'll do that. Just give me a second.
Okay, so essentially I'm going to show only 3 slides with the COVID-19. The major characteristic of this pandemic, as we see it, is between the people who come with disease and symptoms versus people who are asymptomatic. I mean, this is not unusual for an infectious disease epidemic, and especially the respiratory epidemic. But what it shows actually is that out of the 10 people who are actually infected, 2 of them have some form of disease. A quarter of the 2 would have very critical, severe illnesses requiring an ICU, while the 75% of these 2 with disease are mild and moderate and do not necessarily need any ICU interventions, but may require hospitalization. So that gives us an impression of what kind of health services we are looking for. The major concern really goes around here, the 8 of the people in the iceberg. So this is what I'm depicting as an iceberg. 8 who are asymptomatic, and most of the time they are left out of the testing system in most countries because they can't cope with it. And they are the ones who uh, indefinitely, but for certain period of time that we are hearing now scientifically, are able to transmit infection and are very, very important from the epidemic point of view. The next, please. Uh, there are essentially 4 stages of COVID-19 that I think we all want to catch on with. The stage 1 and stage 2, where most African countries and the participants who are connected with this platform, they are actually in stage 1 and in moving gradually to stage 2. So the stage 1 is where the infection is introduced for the first time, while the stage 2 is the local transmission to close contacts and their groups and their own families and communities. The third one is, which is a massive exponential transmission that occurs in terms of communities where people are not able to trace the source of infection. And stage 4 is the widespread outbreak of the epidemic, which is presently, of course, has no end in sight, and most of the countries like US, Italy, and Spain are going through those phases and maybe gradually settle down. Now, beyond stage 4 is what resolution seems to happen. And so when these 4 stages were done, the epidemiologists were not sure what to look at beyond. And that's what has happened in Wuhan, is the subsequent stage of resolution, and as they claim to be 0 cases. The next slide, please. So the 6 webinars that we are now decided on these topics is the first one that we are doing today is global epidemiology. The second one will be on pandemic preparedness and response measurements, looking at the mathematical models and other ones that show the trajectory much more clearly. The diagnostic and testing, the fourth webinar, which are weekly webinars, will discuss the treatment and vaccine development. The fifth one will be personal and institutional preventions. And the sixth is the social and economic impacts. So essentially, this is how we intend to go through the knowledge sharing process of these webinars, but that is the launch process of the network platform that we talked about, the global COVID-19 network, which will be launched and carried forward by the 3 co-sponsors, namely the University of Washington, Seattle, Sambodhi, as well as ISRN. So I think I will stop here, and I will request Mr. Sudhanshu Malhotra to come in and introduce the organization called Sambodhi in India, so that everybody is able to get introduced and see how we are going to be bringing the strengths across all the co-sponsors. So it is Sudhanshu Malhotra. He is a specialist in communications, research, and partnership development. Please come in, Sudhanshuji.
Thank you, Dr. Hira. Thank you, and a very warm welcome to all our speakers and participants. As Dr. Hira mentioned, I represent Sambodhi Research, one of the co-founders and co-sponsors of the Global COVID Network Initiative. I just wanted to spend a couple of minutes talking about how and why we conceptualized the network. And I've got a couple of slides for that. I'll try and share them. Just are my slides visible?
Yes, yes.
Great.
Yes, Sudhanshu.
Yeah,
So,
yes, sir.
before I get into the reasons for conceptualizing the network, I'll take a very brief moment to kind of introduce Sambodhi Research as an organization and what we are all about. We, as an organization, we were incorporated in 2005, and we are essentially a multidisciplinary research, monitoring, evaluation, learning, technical assistance, and data science services organization. The genesis of our organization was based on a felt need at that point of time for statistically sound evidence that could then support policy as well as action and implementation. And that's been our fundamental basis all along. We represent the Global South, and we're proud to represent the Global South, working across regions like South Asia, Southeast Asia, as well as Sub-Saharan Africa. And we do this by providing services in areas like program design and advisory, for developmental interventions, technical assistance and system strengthening, impact evaluations, data analytics, as well as project tracking and monitoring. And From a sectoral perspective, we work across various sectors, but largely this is made up of public health and nutrition, energy and climate change, education and skills, agriculture, livelihoods and natural resource management, and then water sanitation and hygiene. So those are essentially the buckets that we work in. And that's what I wanted to say about Sambodhi Research as an organization. But moving on to the network and why we have it in place today. Well, the network it's an initiative that was a result of discussions that were held between various actors across the public health landscape, including policymakers, including academics, implementers, public health professionals, as well as medical practitioners. And it was an outcome of a felt need for a platform which could capture and disseminate knowledge, insights, learnings, and practices in responding to pandemics such as the COVID-19 pandemic across various regions. The network has a strong focus on South to South interregional knowledge sharing and learning. But having said that, we welcome participation from all corners of the globe. We feel that would just add to the network. Over a long term, we hope to make the network a self-sustaining resource for sharing, for learning, for collaboration on responses on outbreaks. And to start with, we've started with the schedule of 6 webinar sessions. Dr. Hira talked about those sessions. And they essentially plan to address the impact of policy action on COVID-19 on the ground. Now, before I hand over back to Dr. Hira, I just wanted to highlight one of the primary reasons why we thought this network would be important and critical. And that's because the varied response that we're seeing across regions. This is an unprecedented pandemic. We haven't seen the likes of it in most of our lifetimes. Different countries are at different points in the pandemic cycle, and hence their responses are being shaped by where they are, by the challenges they face on the ground, the resources that are available to them, the populations that they're dealing with, and the intensity of the outbreak, and so on and so forth. And hence also their strategy in dealing with the pandemic differs quite a bit. From a country to country perspective, from a local government to a local government perspective as well, we are seeing government response differing in terms of the lockdown. So some of them are buckling up and strengthening their lockdown and containment strategies, while others are talking about opening up of services and economies. A strong case in point can be made about testing strategy as well. If you look at the graph on the right, you'll see that different countries are testing differently. And this is for a variety of reasons, which are very country specific as well. But all of this kind of leads to the point that we need a platform which can capture and document insights from the different responses, as well as the outcomes of these different responses, to ensure that there is a global discourse, especially focusing on the global south, on potential kind of responses to challenges with respect to pandemics and their outbreaks. I think I'll stop here. Back to you, Dr. Hira.
Thank you, Stanshu. We have the next introducer, Mr. Santosh Gupta, who is the CEO of ISRN India. The one he himself is a development specialist and CEO of the organization, which is nationally with 600 networking NGOs and CBOs. So, Santoshi, can you please come in?
Yeah, thank you, Dr. Hira, and especially thanks to you for connecting all of us in one global COVID-19 platform. And also, I am welcome and thanks to Dr. Dermot for sparing some time for this platform. So I'll just introduce the organization like ISRN Indian Social Responsibility Network. Basically, is the network is the very young network, just 2014 is establishing, and we are working with the voluntary organization, corporate, experts, social workers, and the government with the motto of like relationship building beyond funding. That is our slogan, like as we are working. And with over 600 associated voluntary organizations across the country, the organization is trying to make a difference at grassroots level. So ISRN, through its multifaceted approach, is working innovatively in the sector pertaining to health, education, research, and capacity building. And also, it has been able to deliver on the line of sustainable development goal, like related to good health and well-being, quality education, affordable clean energy, and water and sanitation. So, and nowadays we are working in COVID-19 for so many things, like with the objective to support the frontline functionaries and other who are working round the clock to control the pandemic. Uh, we have created volunteer reserve force platform where almost 5,000 volunteers from almost 27 states and the union territory have already registered. So ISRN and its member organization have basically been working in a three major area, like one is mass awareness generation through social media and different platform, and second one is distribution of cook food and grocery items to the needy person, and the third one is the sanitation kit to the needies, and also we are working with the government for the surveillance to support for tracking system, tracking patients and infected populations. So it's a few things we are doing, and we are also did some dialogues with our member organization with our vice chairperson, Dr. Vinay Sahasbudhe. He is a member of parliament in Rajya Sabha. He is also a president of Indian Council for Cultural Relation. And we conducted three states workshop, one for Bihar, Uttar Pradesh, and Uttarakhand in different days. So these initiatives carried out on ground by voluntary organization and are then being compiled and documented in a Corona Relief Bulletin. That's relief bulletin. Those are the Corona Relief Warriors. We are compiling these stories in our through our bulletin. So where in it will provide a holistic picture of the activities carried out to the support people and the government during the lockdown period. The pandemic has hit all countries across the world, but however, India is doing better. It is my personal feel and can be model with a relatively low number of cases compared with the rest of the world. Dr. Darmot, you can better explain. So, the current status, as I know, the coronavirus cases, according to the Ministry of Health, like today, as we reported 29,435 active cases, and apart from that, like 6,869 6,000 patients have been cured, and 934 deaths have been reported so far. So civil the country of the comparison, like US, UK, Italy, Spain, you can see the higher number of cases than India, despite the later having largest population after China. So though there are a struggle the country India is facing, but there is no denying that the government has taken right decision at the right time. As our Prime Minister, Mr. Narendra Modi, has announced Janta Curfew, and that continued the lockdown involving the multiple stakeholder like voluntary organization, private sector, to mobilize and support the action of the government, and will also implement their own innovations. This would be include mass awareness and mobilization at the ground level. So strict rules on movement of citizens, food distribution to the needy, migrants in the local areas, and providing home delivery service. Drone. We also conduct a drone monitoring system in the some areas for following the lockdown system. And government also launch one Arogya Setu app, as I hope you heard about this. And this app will help in identify the risk of getting affected by the coronavirus. So the app can then calculate the risk of infection based on the sophisticated parameters. And if any of these contacts is tested positive, the app will help the government take necessary timely steps for assessing risk of spread of COVID-19 infection and ensuring isolation where required. So evacuating Indian citizen from foreign country and quarantine for safety, providing help, like all these activities we are doing, and also our Delhi government in trying to plasma therapy, which has shown positive result. So hopefully, I think in future this will work. These are the some of the example which thrown light on the government clearly thought and planned strategy to win over corona. So current period of lockdown is true for each of us, but we also need to think ahead and plan for coming month, especially post lockdown period. Especially my opinion is the coming month will also not be easy. Thus, ISRN has a few action plan to address that post lockdown situation. Like firstly, as I said, awareness. And awareness is not just required at the present, but will also be needed at the hour at the point when lockdown is over. So information dissemination, dialogue, like as COVID-19 platform, global platforms, like expert advice will carried out to guide people cope up with the impacts. And also research can be taken up in various reasons. As Sudhanshu said, we need to conduct some research work in the country, regarding pandemic and initiative success challenges, which can be done by engaging the number of voluntary organizations. And lastly, as the economic shock will continue post lockdown for the some time, thus we should be planning for revival of economic in field of agriculture, manufacturing through the planning to address human resources requirements and other safety guideline after post lockdown. So these are the issues nowadays are a challenge for the citizen and as well as the world. So this is my small opinion about COVID-19, and I hope I will do something with this network in India and also as well as our developing country. So thank you so much, Dr. Hira.
Thank you, Santoshji. I think we move on to the first speaker, Dr. Dermot, because he has to then leave in about 30 minutes. And the second speaker has just joined in, although because of the connectivity problem, Professor Yasa from DRC had difficulty joining on time. But Dr. Dermot, you are the coordinator of research and capacity building at DDR in WHO in Geneva. You have been fundamental for capacity building for all the tropical diseases across the world on the 6 continents, and he's very, very well respected in the field. So epidemiology can come best from you. It's over to you, Dr. Dermot.
Thank you very much, Subhash, and hello to everybody who's on the webinar. I'm very pleased to be able to contribute, and Camila is just bringing up the first slide to introduce myself and to complement what Subhash was saying. The special program on research and training in tropical diseases, most of the time when we're not in a COVID situation, we're dealing with diseases that are largely endemic, in fact, a lot of the tropical diseases. And then, of course, in WHO, there's a large program, the emergency program. Now, what we've just found by asking some of the people who we've trained in the past is, probably not surprisingly, a lot of the people who've been trained through TDR, even though their training has been largely on the endemic diseases, they've acquired skills and expertise that they're now using as part of the COVID response. So just to explain that the main activities of TDR normally, do we remember what normal is like? I don't know. The main activities of TDR normally are on research and capacity development regarding endemic diseases. But these skills are often transferable, they're often generic, and they are being transferred, we know that, as people who we've trained in the COVID response. Next, please, Camila. So, WHO, if you don't know the WHO COVID website, it is very good. That's a small infomercial from me as a WHO employee. Of course, there are a number of websites that are providing very good information. The Johns Hopkins website is very good, but of course also the WHO website is very good. And this contains the information that is transmitted to WHO from all of the 200 member states of the UN. So the numbers of people as of yesterday, the 27th of people, were coming up globally to 3 million confirmed cases and nearly 200,000 deaths. So this is, as everyone knows, it's a big deal. This is probably the biggest pandemic since the influenza pandemic that occurred just after the end of the First World War. And estimates vary very much, but perhaps about 20 and 30 million people died of the influenza epidemic in 1919. Commonly said, more people died of the influenza epidemic after the First World War than died of fighting and consequent causes actually during the war. And currently there are 4 countries that account for more than half of all the newly confirmed cases. These are the United States, the Russian Federation, Turkey, and the United Kingdom. I think Subhash and Camille will probably share the presentation later. So to look for the latest data, there are some websites there that you can have access to. And just to say that WHO is an intergovernmental organization as part of the UN. Our remit is to work with governments, and we receive the reported cases and reported deaths. The cases that we're counting are largely the confirmed cases, that is, somebody with laboratory confirmation of COVID-19 infection, irrespective of clinical signs and symptoms. So going back to Subhash's picture of the pyramid, irrespective of whether they're the top part of the pyramid above the water or the lower part of the pyramid below the water without symptoms. So confirmed cases with laboratory confirmation. So the cases are still increasing globally very much. And what I want to do, next slide please, Camila, is to just look at this creature first. This is a pangolin, the poor pangolin. Say again?
Coronavirus.
This is the pangolin. Now, the COVID virus is, like very many human pathogens, an organism that has crossed the species barrier. It's a zoonosis. It's crossed the species barrier from one animal into the human population. This is common for very, very many human pathogens. And probably the story is that there are related coronaviruses in bats, and they've crossed the species barrier into this creature, the pangolin. And then there's been a transfer of the virus from the pangolin into the human population. And of course, there are a lot of complex interrelated factors why a certain virus, in this case, might cross a species barrier into the human population. But all of these factors came together, probably in the famous wet market in the city in China and in Wuhan, and the rest is history, so to speak, as the virus has been transmitted worldwide. Next slide, please. Now, Camila, on my screen, the bottom of the slide, the slide is a bit bigger than the whole screen. Is that, can everyone see the, that's better, thanks. That's it, okay. So what I want to do, having looked at the situation today, I want to take several steps back in time. From the WHO website, I've made copies of some graphs to illustrate the evolution of the pandemic. And it's incredible looking back. It's only the 31st of December when China first alerted the WHO as to the grouping of cases of what looked like a new pneumonia in Wuhan. And this was the very start, the first alert that this was what has subsequently grown into be the COVID pandemic. So going back to the end of January, this is a graph. In those days, at the end of January, there were a total of 82 cases reported outside of China. And at that point, there were nearly 8,000 confirmed cases in China. And the bar chart shows these 82 cases. So when I was looking at these slides and preparing them, I thought this was really, really striking that in such a short period of time, this is just the end of January, we've moved from a bar chart where the vertical axis, the number's a bit small, say 2 cases, 4 cases, 6 cases. this is how we were representing the number of cases outside of China by the 30th of January. Incredible. The next slide, please. Now, by the end of February, we'd moved to this situation for the cases reported outside of China. So these, the numbers on the vertical axis have now changed, so that we're going up 300, 600, 900 cases, but still a very modest number of cases compared to today. So the color code is for the different WHO regions. And at this point, at the end of February, the sort of orangey color is the Western Pacific region, and that is largely representing the large number of cases, the relatively large number of cases in China and also in Korea at that point. And then the sort of pinkish mauvish color is the European region, looking at the right-hand side of the bar chart, where we're seeing the beginnings of the epidemic in Europe. And then the other main element here is the purple color, which is Eastern Mediterranean, that is mostly the epidemic that they had in Iran. So at this point, at the end of February, this is only 2 months ago, incredible. We're looking at the curve going up of the cases in Western Pacific region, mostly China actually, also Korea. We're looking at the beginnings of the epidemic in Europe, and we're looking at what seems to be quite a significant epidemic in Iran. So next slide, Camila. So we have the similar epidemic curve. If you look at the vertical axis, we're now going to much greater numbers. This is the end of March, so just a month ago. So the numbers on the vertical axis, they're going up to 60,000. So you can see the tremendous increase in the numbers that are being reported as each successive month goes by. Now, if you look in the middle of the graph, you've got the cases that are basically in the Western Pacific region, that there's a spike, that is an artifact due to a change in reporting. And those are mostly the cases in China. So if we just look at the middle of that bar chart, the crucial thing that we've seen there is essentially the epidemic started in China. It took off in China. The Chinese authorities instituted some pretty rigorous, pretty intensive, pretty strong measures. And actually, they turned the epidemic off in China. So in terms of what Subhash is asking me to present about, the epidemiology and the trajectory, well, there, the story of China is at first a few cases, a rapid increase, the institution of measures to control the epidemic, and actually they turned off the epidemic. So even a few weeks ago, I think they had no indigenous cases arising in China, and the cases they were reporting were all imported. So that is a very, very important case history, let's say. It's not unique to China. Other countries have done it. So Korea saw the beginnings of quite a big epidemic, and again, through very rigorous all-of-society measures that were very rapidly and intensively applied, they also turned off the epidemic. This was seen in Hong Kong and in Taiwan. Now, just to mention Singapore, until a couple of weeks ago, would probably also be an example of a country that saw the beginnings of the epidemic, instituted very strong society-wide measures, and turned the epidemic off. However, Singapore is now an example of one of the few countries that is seeing the second wave. Because although Singapore turned off the first wave, actually, it's probably fair to say, didn't manage to concentrate on the immigrant workers who actually have now been at the center of the second wave of the epidemic in Singapore. So if we look around the world, nations shouldn't really be wanting to not heed the lessons learned from other nations. Every country now has its experience. And what are the experiences that countries can learn from other countries? So actually, the second wave experience in Singapore is a pointer that other countries can learn from. Now, looking at the right-hand side of the bar chart there, you can see that this sort of pinkish, mauvish color, this is mostly Europe. And for a large part of the time until the 31st of March 2020, there was that exponential epidemic occurring in Europe, starting in Italy and then spreading throughout all of Europe. And then, in fact, just at the end of the bar chart, we can see that probably the epidemic in Europe peaked there and has started to come down. But the main part of the global pandemic was the epidemic in Europe. Now, on the same slide, taking us through to the end of March this year, you can see that the very pale bars at the top have started to come in. So they probably started to come in something like early March, and those pale bars at the top have increased. This is the region of the Americas, and this is mostly the United States of America. So all regions and all countries are seeing the same sort of phenomenon. This is an epidemic. It's a new pathogen entering the human population. It starts off with a few cases and transmits, and there's usually an exponential growth phase, and then the trajectory depends on what is the extent of measures that are introduced to check that epidemic. And so we've seen a complete check of the epidemic in China. We've seen a partial checking of the epidemic so far in Europe, and we're beginning to see a partial checking of the epidemic in North America. And learning lessons, how do we most effectively check the epidemic? And then the next important step when countries reach the peak and start to check the epidemic is how to prevent the second wave. So the cumulative total of global cases by the end of March was 750,000, with 36,000 deaths. And now next slide, Camila, please. So this is the total pandemic curve from the start. So that I think the times are just not on the bottom of the x-axis there, but this is the total pandemic. So going from the beginning of January to the 27th of April. And so just walking through a couple of the key points that we've seen. So looking early on, you've got that peak, the Western Pacific peak that was mostly China with Korea, Taiwan, Hong Kong, and Singapore. That epidemic is more or less over and done with. Then we see the beginning of the epidemic in Europe, the sort of pinkish color, exponential increase. And looking at that set of columns for Europe, the plateau came on, and then we're beginning to see the plateau start to decrease. We've got the bar of Eastern Mediterranean, that again is still largely Iran. The bars are a bit small, but that seems to have been a fairly constant level of reporting. And then again at the top, you've got, it's mostly the United States, America, and the Americas region, of course other countries as well, where the epidemic hasn't yet turned over. Now, an important point that I should have made at the very start is we're talking here about reported cases. And of course, there is a variable relationship between the number of cases reported by a country or a territory and the number of cases that are really happening. And different factors affect that relationship. So of course, what is very important is the testing policy. How many people are being tested in a country? How many cases are confirmed? How many cases are happening but have not been confirmed? So these trends are very important to interpret as the reported cases that can give some indication of the background level of truly occurring cases, but that's an interpretation. Now, if you look at the bottom of the bar chart, the Africa region is a, the Southeast Asia region, I should say. The Southeast Asia region is the blue color near the bottom of the bar chart. So those are small bars that for the past month or so have slightly increased. So this is the question, what is going to be the extent of the epidemic in the WHO Southeast Asia region? The cases are there. It doesn't look like they've expanded quite as quickly as the expansion of cases that took place in Europe and North America. And similarly, if you go to the very top of the bar chart, I'm sorry I don't have a pointer to point you, but I hope you can follow where I'm looking at. Go to the very top of the bars, there are very small bars that are very light blue color, and that's the WHO Africa region. So cases have been reported there for the past month and a half. They remain reported at quite a low level without showing a very, very dramatic expansion. Now the question is, are we seeing few cases reported because there are few cases? Or are we seeing few cases reported because there are lots of cases, but they're not being diagnosed and reported. And to be quite honest, I think in WHO region of Africa, it's a bit hard to say. So in the discussion, I'd be particularly interested to hear from our participants from the countries in the WHO African region, what is their experience? What is their intelligence about what is happening? What is the extent of the epidemic in Africa? The number of reported cases in that region is still relatively small. Is it because the true number of cases is small, or is it because we're underreporting on the true number of cases? Next slide, please. Now, we've heard from earlier presenters that the response involves all of society because the impact of COVID is felt across all of society. We've never in our lifetimes experienced such a phenomenon whereby the news every day for 4 months has been dominated only by one issue, by COVID. It's affected every country, it's affected all of us, it's affected everything that we do. This is new, I think, for pretty much all of us. And in the subsequent webinars, I understand from Subhash that you're going to cover, well, what are the measures that constitute the society-wide response, the population-wide measures to decrease risk of COVID-19 transmission, the measures to break the chains of transmission. And I thought, because I've got some slides from WHO, I might tell you something briefly about the importance of breaking chains of transmission and something briefly about drugs and vaccines. Although I know that these are really going to be covered a bit more substantially a bit later in the webinar series. So next slide, Camila, please. So in terms of diagnostics and testing, we know there are two types of tests. The test of infection, detecting the virus or the nucleic acid of the virus, and test of immune response. So the first one, who has the infection, the second test, who has had the infection. And testing is really important in the public health response. And I haven't watched all of the daily press briefings that the Director General of WHO, Dr. Tedros, gives pretty much every day at the Palais des Nations in Geneva. But I watched one, it must be 6 weeks ago, I think, if not longer. And it was memorable. He said at the end, I want to summarize what I've said in 3 words: test, test, test. And it's very interesting that around the world, very few countries have taken that advice, probably to the detriment of the control of the epidemic, the pandemic. Next slide, Camila, please. So again, I think you'll see this slide probably a number of times, but just to talk about some of the important points here. So it's a slide showing on the vertical axis infection, and on the horizontal axis time. And the blue shaded area in the middle is a period of symptoms. The light blue curve is the curve of the level of detectability of the virus. And then the 2 curves to the right, the black line, which is describing a hump, are the early antibodies, IgM, and the purplish color, the line that forms a plateau, are the late antibodies, the IgG. Now, an important thing, when you look at the phase of infections, the phase when the virus is detected occurs earlier than the phase of onset of symptoms. And I think Subhash referred to this. This is a very important point. We know that some people have the virus and may well be infectious before becoming symptomatic. We still have a lot to find out about the virus and COVID infections, and this is one of the key features. What is the true proportion of people who have the virus before they become symptomatic? What is the duration of that period? And how infectious are they during that period? And how much of those people contribute to overall infection? That's a very, very important issue. Another very important issue illustrated on that slide is about the antibody response. So in many infections, you mount an antibody response, first the IgM and then the IgG. That IgG response, how protective is it? How strongly protective is it going to be? How long is that protection going to last for? At the minute, we don't know. So I'm sure you'll see this slide many times, but there are some very important features there, very important features relevant to how we try to control the epidemic. Next slide, Camila, please. So I mentioned Dr. Tedros, the closing words of one of his press briefings: test, test, test. And very important, identify those who are infected, so that those people can be isolated and try to prevent onward transmission, and also identifying contacts, following up contacts, isolating contacts, trying to cut the chains of transmission. Many countries, I have to say, they gave up on finding and breaking the chains of transmission using testing very early on. The reasons for this, to me, aren't very clear, because this was strongly recommended by WHO. This was really crucial in order to try to achieve what a number of countries achieved earlier on, for example, China, Korea, Taiwan. When countries are not finding and breaking the chains of transmission, then they're moving into the phase of mitigation of the epidemic and population-wide measures, but not being able to do the basic public health essentials of an epidemic of infectious disease, basically finding cases, isolating them, contact tracing, quarantining them, and trying to break the chains of transmission. So strong advice from the start of the epidemic from WHO, advice some countries have taken up with good effect, advice that many countries haven't taken up, actually. Next slide, please. Very briefly onto the drugs and vaccines. I know you're going to cover these in later webinars, but this is some information that I picked up from WHO that I thought would be useful to share. So if you're interested, please go to the WHO website and get the details. But people are saying, okay, we're in lockdown. We hope the lockdown will finish. And then when we put our heads above the parapet after lockdown, what's going to happen then? And the research community is working very hard to try to find out which, if any, drugs may be effective in preventing infection, in treating infection, in limiting infectivity. And so WHO is coordinating the Solidarity clinical trial for COVID treatments, and the 4 drugs that were chosen on the basis of laboratory, animal, and clinical studies of those 4 drugs there. You can read them on the slide. So the Solidarity clinical trial is underway to try to find out which, if any of those drugs, may prove to be useful in dealing with the COVID epidemic, both for individuals and from the public health point of view of trying to blunt the epidemic. Next slide, please. And similarly, we're all hoping that the research community will be able to develop an effective vaccine very quickly. Again, this is very uncertain. We don't know for sure if it will be possible to develop a vaccine against COVID-19. We don't know how long it'll take, but the good news at any rate is that 3 candidate vaccines are in clinical evaluation. Those are shown on the slide there in the table, and there are another 67 vaccines in the preclinical development phase. So the field is strong. We know in general that it's a long race and a difficult course for vaccines, and there may be very many starters, and of course it may be only one, if any, that arrives at the end. So we'll just have to wait and see if through this expedited process of speeding up vaccine development, there will be a vaccine, we hope, as soon as possible. The earliest people are talking about is possibly within about, say, 18 months. So this is not going to be the immediate step that is going to save the situation. Next slide, please. So that's summarizing, I think, what I just said about the vaccines. Next slide, please. So when Subhash shares the slides with you, here are some links that will provide you with interesting and useful and valuable information from WHO. So just to say that one of the big pushes in this epidemic, in this pandemic, is for every individual, every citizen around the world, every person around the world to become as equipped as much as possible with the information that we all individually need and collectively need to try to respond to the pandemic. And then, of course, good information is also the enemy of bad information. There's a pandemic of bad information that is being spread by a whole range of people, some of whom shall be nameless, of course, we've heard about the past couple of days, but the responsibility lies on all of us to make sure that we are knowledgeable. Our knowledge is based on what we know, and that we help to contribute to the good info pandemic and help to diminish the risks and the possibility of harm caused by the bad info pandemic. And I think that's it. So that's the end of my presentation. Thank you.
Thank you, Dermot. Very clear, excellent presentation. Thank you for being here. The message is very, very clear that we continue testing and keep on expanding on testing so that we know who are infected and who are transmitting and look at how to reduce the transmission. The message is pretty clear, very good slides. Thank you so much. We have 5 minutes left before you think you could leave. And so if there are any questions that anyone has, you're most welcome. Just if you can flag it, I will see that who's flagging it so that we can then ask for the questions to come in. Are there any flags? I can't see them though. Hello.
Hello?
Yes, Professor Yasa.
Yes.
Yeah, please come in. Yes, you are the next speaker, so you can ask a question.
Having a lot of internet problem. So I think I was just following the presentation, but it's cutting, but it was a nice presentation. I'm just liking to ask the speaker about the funding mechanism. How is it working? For this is like in Africa, the funding mechanism to fight the COVID-19 is a big problem. I don't know what WHO is trying to organize the funder to establish the funding mechanism for this, because we're facing a lot of problem for funding mechanism. That's my question. Because we fight Ebola because the funding mechanism was in place. So for COVID, it's a big problem. I know there's a collapse for economy in the world, but I don't know what WHO is thinking.
Okay.
Yes, so thank you, Dr. Yasser, for that question. I think there are a number of aspects of it. Of course, every country has responsibility for trying to galvanize national resources to contribute to the problem in each country. And then, of course, as you say, there are intergovernmental organizations, part of the UN, for example, WHO, that also have a role in trying to galvanize the funding available. A couple of things. WHO, in the aftermath of the Ebola epidemic, did set up a contingency fund so that they were asking the nations of the world to contribute to this contingency fund so that in the event of another epidemic, money would be ready straight away. There wouldn't be a gap while WHO was looking for money from countries to try to mobilize to then spend on the epidemic. So a contingency fund was developed, and that has been used to try to fund some of the international activities related to COVID. An important funding mechanism for research that was set up in the aftermath of the Ebola epidemic was the creation of the Coalition for Epidemic Preparedness and Innovation, CEPI, or people call it CEPI. So a number of countries and organizations contributed money to set up a pooled fund so that, again, in the event of another epidemic, there would be funding available very, very rapidly to put into the research and development to develop new drugs, new diagnostics, new vaccines. So there is a problem, of course, I think, as you hint at, that at the time when WHO is trying to raise money, along with others, in response to COVID, then the global economy is crashing, and so nations have less money to give to WHO. And then, of course, there has been the threat from the President of the United States of America to for the US to stop funding WHO, and the US is the single biggest funder of WHO amongst the member states. So a very difficult area, but an area in which I think there were some lessons learned from the Ebola epidemic, principally in relationship to countries of the world putting in pooled funding for the contingency fund for WHO, and countries and other institutions putting in money for the fund that will try to move forward quickly the research and development for the drugs and diagnostics and vaccines.
Thank you, Dermot. There's a quick question from Dr. Vikas Chaudhary, and he's asking, what is your opinion on testing issues in low resource settings? Testing essentially for infection, I guess.
Yes, well, in a way, the issues for disease control are the same in countries, whether they're high income, middle income, or low income. Ideally, WHO is saying, in order to try to find and break the chains of transmission, you need to test and test widely, and test the people who are presenting, probably also do studies to find out what is the population prevalence of infection. The practical issue comes that some countries, their need for testing exceeds their capacity for testing and exceeds the number of tests available. So many countries are now in the situation trying to run to catch up, to try to stimulate the production of tests, to try to maintain the quality control of tests, and to try to roll out testing so that they can start to fulfill the strong advice of Dr. Tedros, the three-word advice: test, test, and test.
And it's a wishful thinking with so many logistics and other quality control issues in that expansive testing. India just recently saw the issue about antibody testing kits that came in, and there are a lot of issues. Just because the supplies is scarce and there are fewer suppliers across the globe. So I think I won't hold you up, Dermot. I think you have to rush to another meeting. Thank you so much. And thank you, and thanks to Dr. Tedros for giving the big lead to this pandemic. It's a big challenge. So thank you once again, and we'll keep calling you back whenever as we grow along this platform. Thank you.
Many thanks for having me, and apologies I have to leave for another commitment. But I wish you all success with this webinar and the future series. Thank you.
Thank
Sure,
you. Thank
sure,
you,
thank
Dr. Dermot. Thank you.
Bye-bye.
Our next speaker is Dr. Yasa. Peter Yasa is Dean of Medical School in Bukavu in DRC, an old friend of mine for decades. He has wide experience of public health with HIV/AIDS program and Ebola control. And one of the reasons why we requested Professor Yasa was with his experience of having skillfully steered and handled the various episodes of Ebola as they emerged in this part of the West Africa and a few of the Sierra Leone and other countries. There are several successful lessons and success stories of Ebola that have not been heard during the COVID discussions in the epidemic. So, Professor Yasa, we would like to hear you, and we have 15 minutes for your presentation, and then I think we need a little time for Dr. Judy's presentation so that we close on time. Thank you. It's over to you.
Thank you, Professor, and all colleagues and viewer for this wonderful conference. I'm not going to say too much since the WHO have already updated us. I'll just give you our Congo DRC pandemic statistic updated up to date, and I share with you our experience, how Ebola experience can help us to control this COVID pandemic. I don't know if somebody can put my first slide. Somebody can put my first slide. Okay. Okay. Next slide, please. Next slide. I'm going to share with you this COVID virus. Like you know, that COVID that can enter in the body, maybe in the lung, so affect the pneumocyte 2 and the pneumocyte 2 specifically. So there's a specific receptor that occur, angiotensin 2 receptor. That's the COVID like to enter. We find that cell with those receptor in the lung, heart, and the kidney, intestine. So next slide, you can see COVID affects 10 times more that receptors. So as COVID is a COVID virus, so it affects the respiratory system, and then it's found more common in the animal and the human, but like we said, is a zoonotic virus. Next slide. Next slide, please. So, as remind us by WHO, COVID virus started by in the Wuhan city in China. So, like they say, the zoonose maybe started by the dry animal they're selling in the market. Next slide, or live animal in the market. That's why they think people buy those dry animal. Maybe it was the first spread of the COVID-19. Next slide. But they're still thinking. Next slide, please. Next slide. Next slide, please. Wow.
Dr. Yasa, do we still have you? I think there's been a connectivity issue.
Yes. Okay. So maybe he has the internet problem, but he might come back.
Our internet is
Okay, you're back.
Okay, can you go to the third slide? The third slide. No, before that. Go ahead again. Okay, those are our, okay. So in Congo, we are, before that slide, please, in Congo, we are organized. We have a note, next slide, before that slide, please. Before, okay, we're here. So in Congo, COVID, we are very organized. So you can see our map, Congo. So we, so far, up to date, we reached 459 cases, and then it means 6% are lost, so 28 deaths, and 50 cases, that means 16% have healed, and 381 are still under monitoring. They are positive, but are still not yet under monitoring. Next slide. Next slide. As you show, you can see we have less deaths, almost 6%, and then we heal 50 cases, and then 400 cases are still under monitoring. Next slide. Next slide, please. Alors, I want to share with you how The distribution is under the province. So let's go move ahead. Before that, please. Somebody before, go back in the provinces, go back. Next slide, next. Go back to the province. After this, next slide. Next.
Dr. Yasa, could you just mention to me what
Next slide.
Could you just mention to me what the number of the slide is, and I'll click on that then.
Okay, so we are in the province. So the next slide talking about the provinces. Slide number 13, I think so. Okay, number 12. Number 12, slide number 12. Okay, so in terms of provinces in Congo, you can see all the epidemic for COVID is found in Kinshasa. So why Kinshasa? Because that's the capital area where all the tourists, the business people who are coming from Europe, the big airport is in Kinshasa. So that's why the COVID is found more. And then we found five cases in North Kivu, near Rwanda. All these five cases are healed. And then in the South Kivu, we have 4 cases. These 4 cases, it was a 10-case people in quarantine. Only 4 was confirmed. And all the 4 are healed. So the Ituri, we have 1 case is healed. And the Kwilu, 1 cases. And the Katanga recently, so 1 cases. So we have more the cases in Kinshasa. All the province cases except for Katanga, not yet, and under monitoring. Okay, number 13, next slide. We have taken in Congo. Next slide. Next slide, please. Okay, so in Congo, we just get the framework. We just follow the framework. Next slide. Next. Let's go to the framework we use in Congo. That's the formula I put there. Number 13, number 14. Number 14. Okay, there. So which framework we use in Congo? So what we are trying to do in Congo as a measure in our fighting for the COVID, we're just trying to reduce the reproductivity rates. So as you know, the reproductivity rates equal to transmission efficiency, beta, multiplied by C, the contact, the exposure rate, and by duration of infection. So what do we do? We're trying to reduce the reproductive rate at 1. So if we manage to reduce the contact exposure less than 1 over beta to T, so that's what we are managing. Since we don't have a B, we don't have to work on B, on beta and D. We need to have a treatment. We need to have a vaccine. We don't have. So what we are trying to do is to work on a contact by social distancing, quarantine, washing hand, and mask. So this, I think people are changing their behavior. It's almost the way we fight Ebola. So that's the formula for reproductive rate. That's why we are working on that. Next slide. So I think we're trying to manage, like all these provinces like Kivu. So you see we're using this formula. So we're trying to use wash hands and using the mask and the social distancing. So restriction, we close the school. So we're trying to avoid all the mass people together because that's we can spread more the COVID. So but we have some challenge in our country. For we don't have enough cases, but how do we end it? So we need to do a testing like a WHO say. But you can see in Congo now, the testing is only in Kinshasa. So the lab for testing to all the provinces, you know, Congo is like a continent. Now they stop all the plane moving. So we are using like the UN plane to send the blood, if there's a plane or not. So all this is to delay. So we have only viral testing lab is in Kinshasa. Problem. But contact tracing, so we are trying. There are so many innovations. Some like here in Bukavu, they are making some program for and a phone contact tracing using the phone, the smartphone. Like CamCare also proposed us to do the same thing. So then for the treatment, like you know, we are just using the protocol using in France with chloroquine. So we are trying to borrow also the Indian and prophylaxis. So people were contact positive before they develop the disease. We give them the program they're using for Indian, but we adapt it. So we did 400 milligram twice for 3 days, and then 1 tablet for 11 days. So we do like trying like to do some study on that to get evidence-based practice. Okay, we don't have a vaccine, so but the monitoring, we have a monitoring system in place, and preparedness, we have at least so many hospitals in the country. Only 3 hospitals are ready to receive the cases for coronavirus. So we don't have those equipment, respiratory. We have only 50 representatives of the whole country. It will be very difficult for us, but still we're trying to use our experience for the past experience for Ebola. So let me now discuss with you our next slides, our experience of Ebola, how it can help us to reduce our, like the last Ebola outbreak, it was in Beni, in the southern, northern part of Congo. So it was in Beni, Butembo, Kenya, and Goma. So that's why it's a case. But we managed to end it. Normally in last month, we were supposed to declare end of Ebola, but 1 case raises. So that's why we delay a bit. We're doing a contact tracing to find where this case comes from. Next slide. So our first experience that helped us to end up Ebola, it was research. So during that outbreak, research was doing there. So we're doing a treatment research, that's really work. We're doing a vaccine, so proven the vaccine, it was working, and some treatment was used, 2 molecular using, that's work. Next slide. Next. And then the second one, there was a testing, like WHO will say, test, and treat. So you see, we, like now, the test is found only in Kinshasa, and the PCR test. We don't have any rapid test. So all the provinces, we don't have a test. So you see, but in Ebola, we have a test, a rapid test, the point of care, a gene expert test. So you see, it was a DNA test. So it was very quickly, and then we detect fasting, we put in treatment, we quarantine everyone, we test them, we put them in treatment. So it was a good experience. That's what we can borrow them for the COVID. Next slide. Next slide. So again, we use a vaccine. So you can see even the health workers. Health workers, they are not being protected. For Ebola, a lot of health workers was dying, the doctors, because of no protection. But now, for Ebola, all the health workers were vaccinated. So they was protected. And all the equipment, the PPE, it was there. So you can see the vaccine also help. So even the population. So that's the example. Even if people don't like vaccine, but the vaccine is very, very important. That's the only one that helped to end Ebola quickly in Congo. Next slide. Next. Another experience for us Ebola was a treatment. 2 molecule for treatment was used. So MAB 114 and Reagan, it was used. And 90% of patients was received that treatment, their viral load become very even undetectable. So you can see all this was also experienced. So research is very important on this particular COVID-19, but we need to sensitize people the importance of research. But a Congo is an example of this pandemic Ebola. It was ended through research regarding the new treatment they are using, and it worked at 90%. It reduced the viral load. Next slide. Next will be the end. Okay. Also, the survival supported. So people who survived from Ebola was like a testimony. There was also like using their parts to sensitize other people. So it was very positive. Next slide. Next slide. Okay, and the community engagement, social science, the community engagement is a very, very, very role player on that fighting for Ebola. So all the community were engaged on this fight. Even a COVID, I can see even here, some people don't believe on COVID. So you see, there's not really sensitization of the population. So we need to sensitize them. Borrow for that example for Ebola. I think it will help. Next slide. I'll give you some example for picture from Ebola and the COVID as the last part, it was my question, the funding mechanism. The funding mechanism was we really have a funding. So the money was put in place, contributed to really end quickly that's Ebola issue. So let me share with you some pictures where I can end my presentation for our Ebola. There's like a similarity with COVID, but Ebola can be that's exanthema avec necrotic and bullets. You can see that's bullet is Ebola. So that's very common for Ebola. Next slide. You can see COVID also have a fourth inflammatory process. So that can release so a lot of histamine and the cytokine that can lead to vasodilation, can also type 1 allergic reaction, can be dermatitis. So you can see how this similarity you can find also in Ebola. And even so those lesions, it can maybe confusing between Ebola and then even Ebola is hemorrhagic, but in the beginning, you can confuse it with COVID. Next slide. Those are the picture I've chosen for you. So I think we need to work together. Like you develop that program, Asia and Africa. I think we need to share our knowledge and share our knowledge like Professor Ira. We're sharing knowledge. We're trying to make our mask for our population. There's money to buy the mask for N95. We're trying to do it at home. We borrow India system. And then like we now borrowing now the Indian prophylactic drug for preventing people COVID positive, like the health workers who are in contact. So we put them in a treatment. I even see in America they are using the same Indian prophylaxis system to do their trial. So for prophylaxis for COVID, I saw it in the presentation in the US, in the University of Washington. So they are trying to get 2,000 people on this trial. So thank you very much. Is there any question? I think sorry for the internet connectivity. Wow.
Thank you, Professor Yasa, for an excellent presentation. I think it's very helpful. What we are seeing is that the age of science and reasoning is coming back. We have scientists today on this first webinar, everybody talking about science. So the usual process of celebrities and glamour is over in terms of pandemics. Something like what we saw in HIV/AIDS lot of glamour and celebrities took over at a certain point in time. But we are happy that scientists are back in this pandemic to be able to respond. I think we have just a few minutes. I don't know, Camilla, are we going to be knocked off at 7 o'clock, or we have a few minutes to continue for question answers?
No, we have time. There is one question, in fact, from Jane. She asks, one second. She asks, how viable is test?
Yeah, I think exactly the same response that Professor Dermot gave was the issue about funding for a pandemic, because Ebola was an epidemic in 3 or 4 countries. They were able to lock down the countries very early in Africa, which was not the case in this case of COVID-19, because we only knew about the pandemic, the epidemic, only 6 weeks after it was already on in China. So there have been some issues, but now when you're talking about test, that's a strategy that science brings. That if we do that, we know how many people are infected and how best we can quarantine them, rather than cut down or close down on cities. The question is funding, and that funding hasn't come together in terms of normally WHO is able to put together, but for a pandemic, I don't know if an organization like WHO can do that in terms of billions and billions of dollars getting into testing. So the answer to Jane is, it is more about issue about funding that Professor Yas also raised, and we don't seem to have an answer right away. But some countries like India has been able to move on with commitments that from early May, 100,000 tests will be possibly done every day. So I think countries are finding resources, finding the logistics of doing it. I'll stop there, and I believe there is time, so open for questions for Professor Yasa with COVID. Again, the question, I will ask you one question that is very evident, is that your testing in Congo, with 85 million people population in that country, and only one testing center, you're saying, you've got only one lab or few labs in Kinshasa. How prevalent or how easy is it for people to test?
Thank you, Professor. That's the other question people are raising even in Congo. They say, why are you putting all the prophets in quarantine? Okay, where we have only one center for testing, where they test only maximum 150 people per day. It's very difficult. So that's why we are claiming if they can order the rapid test. Okay, so they put the rapid test, the IG rapid test, so they can put it in different hospital, different provinces, so that can be better. It's a very big problem. So people, they can put me in a quarantine, but the test, it's done later, maybe 1 week later. So it's a big challenge.
Yeah, just a quick one here, that the rapid test, what you're talking about is antibody, but there are also now the Korean antigen tests. It's the same thing that was happening with so many other infectious agents like Ebola or HIV and all. So you can always look at that as one more option beyond the PCR test. Any other questions?
We suggest that, Prof. So in China, they have also rapid tests. So we suggest the government, but you say there's a one center for coordination, they just use a PCR. So we told them that it can't work on that way.
True.
Okay.
Okay. Okay. The question was, test kits are not easily available. Jane has asked a question to the panelists, to Professor Yasa, that test kits are not readily available.
I think we have a question from Paul.
Okay, yeah. Paul, come in, please.
I have a question. You're speaking about test, but how reliable are these tests? Here in Belgium, I'm in Belgium now, there are many false positive and also false negative. So, has anybody an idea how reliable are these things? Thank you.
Okay, I think there is a full session, a webinar, which is a third one, which is going to deal with testing and diagnosis. Can we probably leave it for that point so that we finish the epidemiology? And Paul, I hope you are able to come back. The next webinar is going to be on the 5th of May. So we are going to be weekly on. So for the 12th May, if you can mark it out the same time, you're most welcome to join us, and we will have the best people who are immunologists and microbiologists to be able to bring those things in detail. If there is any other question, is it possible that WHO can come up with SOP on testing? Well, every WHO has come up with the SOPs on testing. They have the guidelines for testing, and each country then has adapted them according to their own needs. But the question here is that there are so many manufacturers of these kits, both the PCR kits as well as the rapid kits. The rapid kits, again, of two types: antibody rapid kits and the antigen rapid test. And all of them have difficulties because they have had not enough time to quality control their products. And we are seeing, of course, there are a lot more things. There's suddenly a huge demand versus the supply. The question again is coming, how long will it take before we all have the test kits, mostly for Africa? So I think we will just wait for 12th May for our lab experts to address some of these questions. They are very nice questions. I think this is the exact thing that we want to be able to exchange knowledge, how India has been able to cope with it. Soon, next week, I'm told, the Indian RT-PCR kit is coming out from an Indian government research institute in a very large number that they have been able to upscale, and also from the Indian Institutes of Technology that have gone into this. But I think I'll leave it to the experts to be able to bring it up next week. So I think we have answered this question. We have a recorded presentation of 5 minutes done by Professor Judy Wasserait. She's the chairperson of the Department of Global Health at the University of Washington in Seattle. She's my boss, and she has, because of this 10 hours time difference between the places across the globe that we are connected, she has sent us a recorded video. So I think we will just move on, if you permit me to do that. Yes. And then we can again come back to a few questions if we have time.
So all of that brings us to that mantra that we all keep hearing: flatten the curve. The concept that we need to implement policies and non-pharmaceutical interventions to buy time so that we don't overwhelm the healthcare system capacity, and therefore are able to save lives by continuing to deliver high quality care. The other thing that we're trying to buy time for, actually, is to give researchers a chance to the kinds of, to develop and test, actually, the kinds of tools that we need to deal with this pandemic: diagnostics, drugs, and vaccines. Another way to think about flattening the curve is that we actually want to increase the doubling time of national and localized epidemics. And hopefully this will work here. Good. This is encouraging. Yes. Let's see if we can do this. I think this is a beautiful depiction. The end point of that video would have shown you this, this figure. And you can see, for example, for the United States, how the doubling rate declined from roughly a doubling rate of every 2 to 3 days to now about every 9 or 10 days for the United States. And here you see the same or an analogous set of estimates for major metro areas, with Seattle having now moved from decline to about a double time of every 2 weeks, which really gets us to the point where we start to be beginning to be able to control this epidemic right here. Again, I want to emphasize, however, that there is probably substantial underdetection of cases. So people have raised questions about the reliability of some of these estimates. But overall, I think the message is that we are beginning to see traction with some of the policy interventions in some cities and some parts of the world. So the real question, of course, is what do we do to flatten the curve and ultimately control this pandemic? One thing that I learned as an infectious disease physician and epidemiologist is that if you want to beat a virus, you actually have to think like a virus. So if I were a virus, I would most of all want to do two things. I'd want to survive as long as possible, and I'd want to reproduce as much as possible. One of the best ways to spread and both survive and reproduce is to link my spread to essential human functions. And two of the best ones are breathing and sex. This virus, of course, is a respiratory virus, and the primary transmission mode is large droplets as a result of coughing or sneezing. Second thing is to travel undercover. We do know that this virus is transmitted even in the setting of asymptomatic, minimally symptomatic, or pre-symptomatic cases. Although I have to say we don't fully understand how efficient those different types of transmission are. The third thing is if we want to, as a virus, I would want to stay as infectious as long as possible. We're still learning exactly what the infectious period is, but it's pretty clearly longer than the symptomatic period. The fourth thing is that I want to be slow to kill or severely debilitate my host, so that I could have a way to be carried to the next, to infect the next person. And with more than 80% of cases being minimally or moderately affected, I think I'm in good shape here. Finally, I want to be able to change my appearance, change my coat. And here we're still learning exactly what kind of mutation or evolution rate SARS-CoV-2 has. Which brings us to the concept of the reproductive rate, or R sub 0, of infection, the average number of new infections resulting from each index infection. The reproductive rate is the product of three factors: beta, the transmission efficiency; C, the contact or exposure rate; and D, the duration of infectiousness. So to control and ultimately end a pandemic, we need to drive R sub 0, or the reproductive rate, down to less than 1. So one way to do that is to decrease C, the contact or exposure rate. And that's what we do with social distancing, things like hand washing, masks. But if we want to be able to drop back and de-escalate from social distancing, let our contacts with other people start to increase, the other way to do that is through vaccines or treatment, which decrease beta, the transmission efficiency, or the duration of infectiousness. So finally, what do we need to do to end this pandemic and de-escalate? Probably at least 8 things. First of all, we're going to need widespread viral and serologic testing, ideally home-based, not just home-based specimen collection, but actual home-based testing, sort of like pregnancy tests. And that'll have to be linked to more extensive contact tracing, potentially even assisted by mHealth platforms or IT assisted, and there's some work beginning on that front. We're also, of course, going to need both therapeutic and prophylactic drugs and vaccines, but then we need to have the delivery systems to get those things to the people who need them, and the surveillance systems to be able to do the monitoring and evaluation to understand when we need to expand back to more social distancing for a time and then back off. We also need sustained funding for pandemic disease preparedness programs and research, something that we have never had, despite a series of pandemic outbreaks previously. And finally, we are going to need, these pandemics by definition are global. So we need ongoing global collaboration for prevention and control.
Okay, this is a brief presentation that we saw, and I guess we have a short overtime by 20 minutes. So nice that everybody still attenders are still around. What I suggest is that if there are no burning questions, we can actually move these some of these questions to the next time, because on the 5th of May, the same time, we will have 2 more presenters, one coming in as a senior country program manager from Zambia, Dr. Alvin Winga, and a statistics expert on artificial intelligence, where they are now using simplified methods of artificial intelligence from the testing data that keeps on coming real time, and be able to determine which country is going to be coming down to 99% to 0 level of new infections. So there are regression analysis that are much easier to understand for everybody. You don't have to be a statistician to appreciate what some of these experts are coming up with this. So I hope that you are all able to join on the 5th of May on country preparedness in African scenario, and then a statistical wizard coming from one of the best Indian Institute of Technology statistician who seems to have worked on artificial intelligence. So with that, I wish to, on behalf of this...
Just one last question, if you
Yes.
could answer that.
Okay.
Dr. Amy asks, is the test currently used consistent everywhere?
The question is what?
Is the test currently used consistent everywhere?
Okay. What the question seems to be is that RT-PCR, reverse transcriptase polymerase chain reaction. So that is a molecular diagnostic. And RT-PCR is a technique which you use for multiple infectious diseases and organisms. You use the same technique for using a base of HIV or a base of Ebola genetic material, or use the base of a COVID, and then use this test. Now, this test originally and standardly prepared by 3 or 4 companies in the world. And I will not name them so that I stay out of conflict of interest. But there are companies that have been in molecular diagnostic for 30 years. And they have very good quality assurance. And those are the ones, but they do not have tremendous scale up to be able to supply the whole world. As a result, there are lots of RT-PCR companies that have are preparing these kits from China and in South Korea, as well as now in France, and many more countries. The question is, one good one I said is coming out from a government institute owned by the Indian government next week. So there are the same technology or the technique. The producers are different, so their antigenic material they use would be different. So the answer would be the kits would have their sensitivity and specificity that is vastly different, and can be different if they are not careful with their quality assurance, with the kind of rush they have of a pandemic. I think I've tried to answer this question and not touch their names. We will leave this on the 12th May. We will have the lab experts come in who will then give you a little more detailed things on those. So we should be able to move on peacefully. So till then, it's thank you from the 3 sponsors of this platform that we talked about, the Global COVID-19 Network, formed by Sambodhi, ISRN, and the University of Washington in Seattle, so that beyond bringing scientists back into the center stage of this pandemic, we will look towards bringing more and more public health practitioners and institutions and the CBOs and the national governments to put efforts together. So till then, till next week, 5th May, it's a goodbye on behalf of the sponsors. Thank you.
Thank you. Thank you, Dr. Hira. Thank you.
Thank you.
Thank you, Sudhanshuji. Thank you, Dr.
Thank you,
Perry.
everybody. Thank you, Professor Yasa.
Yeah.
Thank you.
Thank you.
Thank you. Bye-bye. Good night.
Good night.